Welcome to Doc Talk, a weekly podcast featuring Monument Health physicians addressing medical topics. Tune into your health with Monument Health. Hello again, everyone, and welcome to another edition of Doc Talk with Monument Health. My name is Mark Houston, and joining me today is Dr. Catherine Fernandez, who's a sleep doctor here at Monument Health. Welcome, doctor. Thanks for coming in.
No, thank you so much for having me. I'm a fan of the podcast.
Oh, well, thank you.
It's a pleasure to be here.
It's always nice to meet the fans. No. You are so new here, aren't you?
I am.
Where did this journey start for you, doctor?
Well, I guess it started a while ago. Sleep medicine has always been in my radar. I actually did my residency training knowing that I wanted to pursue sleep medicine, which is usually uncommon. Most times people just go through their residency and depending on their interest, they will decide on the type of fellowship training they want to pursue. So I did my residency training in New York, family medicine. And after that, I did my fellowship training at Dartmouth in New Hampshire in sleep medicine.
Okay.
So the good thing about training in families is that I have the opportunity to not only treat adults, but also children, which is kind of like my passion, be able to cater and provide the medical expertise I can to all populations, not just one.
The sleep medicine part is just super interesting, I guess, because it does seem like is it a newer field? Is it uncommon for a lot of people that are getting into the medical profession?
So yes, it's relatively new. It actually started to be more of a formal type of training after the 1970s. And it started at Stanford in California. Mm-hmm. And so over the years, different programs started to kind of train in this. At Dartmouth, we had the Mike Satea. He was the doctor that actually created the ICSD, which is our manual to diagnose sleep disorders. And different universities have other areas of expertise within the field of sleep. So yes, it's kind of like a relatively new specialty in comparison to cardiology, neurology, and all these other ones.
Well, sure. I'm assuming that most people thought, well, if you just had a bad night's sleep, you had a bad night's sleep. You get caught up with it later. How could it affect your health, right?
Absolutely.
But I think with what you're going to talk about today, I think you're going to explain that pretty well of how it does. So what are some of the most common sleep disorders you find in adults and children? Are there common ones, or are they pretty separate?
Yes. So yes, I agree. There's common ones like obstructive sleep apnea. Mm-hmm. It can be seen in children. It can also be seen in adults. Obviously, the presentations would be very different. And I know that in other episodes of the podcast, you've had other experts talking about sleep apnea.
And I have it, so I know very well what you have to do. Yeah,
exactly. So I won't go too much in detail for the adult version of the obstructive sleep apnea. But for pediatric patients, we just need a child that has some sort of symptomatology, either concerning for snoring or some sort of daytime symptom, whether that's sleepiness, temper tantrums, behavioral challenges, learning disabilities, to consider a sleep study or a sleep evaluation. And based on that, after we have the objective data from the sleep study, we would be able to say if this child is actually struggling with obstructive sleep apnea or not. It's not uncommon to see these children going through ADHD evaluations and some other health conditions when in all reality, they were just so sleep deprived because their quality of their sleep is not the best.
So this should be something that parents obviously should consider.
Absolutely.
It's not just like we said, you didn't just have a bad night's sleep. There could be something else going on there. So would you recommend that they, when they go see their doctor, that they bring that up?
Yes, absolutely. And usually pediatricians or primary care doctors ask about the child's sleep, especially when they're very young. However, if you find that that's still a problem, there are some behavioral issues if as parents we haven't established a good sleep routine, or if our schedules are very flexible, that may also impact the child and their ability to fall asleep at night.
Right.
So there's also a behavioral and social component in that. However, if you're seeing your child is kind of like breathing a little heavy at night, or sometimes they stop breathing for a few seconds and they may snore, but it's very softly, it's worth trying it. I've had multiple cases, but I had a case that always comes to mind. It was an 8-year-old child. She was just having some challenges at school, and they thought that she may be struggling with hyperactivity, probably ADHD. Mom added that sometimes she was having some issues breathing at night, but nothing too out of the ordinary. It was mostly when she was sick. We did the sleep study, and it turns out that she had 84 complete and partial pauses in her breathing.
And that's a lot.
That's a lot, even for an adult.
Right.
Yes.
Yeah.
And for this child, we proceeded with the first-line treatment option, which would be removal of her tonsils and adenoids. And I saw her at follow-up 12 weeks after the surgery. We repeated the sleep study then, and her AHI was down to 0.2, which is
wow.
like
Yeah, that's
you don't have anything.
right.
Granted that the pediatric criteria is a little different than adults. We talk about pediatric obstructive sleep apnea when they have at least one pause, complete or partial, in their breathing per hour of sleep. And the severity ranges will also change. 1 to 5 would be considered to be mild obstructive sleep apnea. An AHI, meaning apnea-hypopnea index, of 5 to 10 would be moderate, and anything greater than 10 would be considered to be severe, which is different. Adults,
Right.
that would be mild, all of those parameters. So that's why it's so important to have a specialist, take a look, talk about it. The worst that it can happen is that it turns out that the child does not have obstructive sleep apnea, but if they do, at least you allow them to have the opportunity to kind of have that evaluation.
Yeah, and get the treatment, obviously,
Correct,
too.
yes.
Now, you said something interesting with kids, and you take out their tonsils and adenoids. Can that work for adults, too, that have sleep apnea?
So we've done multiple studies to look at that.
Because I have my tonsils and adenoids, and now I'm wondering, wait a minute.
Yes, it doesn't usually. So after a certain age and after you fully develop your respiratory tract,
Yeah.
it doesn't really seem to show a significant improvement in the AHI,
Okay.
unfortunately.
Right.
And obviously everybody's different. Right now we're leaning more towards precision medicine, and we're looking at endotypes for obstructive sleep apnea in adults, especially because there is a subset of the population that do not really do that well with CPAP or have more challenges than other people to adhere to CPAP therapy. And with the advent of these other medications like the GLP-1 analogs, Wegovy, Ozempic, Zepbound, Mounjaro, those are potential solutions for those cases. So I am expecting that in the future we would be able to better determine who may benefit from a different approach other than CPAP. But as of now, that's the most effective
Sure.
treatment that we have available.
Well, speaking of adults now, what are some more outside of an apnea? Does that seem to be the biggest sleep issue with adults? What are some other ones that interest you or you think people should know about for adults?
Oh, absolutely. So when I started my interest in sleep medicine, I was more interested in circadian rhythm disorders and all these other pathologies, thinking obstructive sleep apnea is just the same, you know what's going on, it's just some sort of challenge in their breathing. However, as we learn more about it and as I have been more exposed to the field, you find out that obstructive sleep apnea can mimic pretty much everything. That's why it's so important for us to determine, first off, if you do have any challenges with your breathing at nighttime. And after that, we can proceed and think about other options. One of the other health conditions that is very common in adults would be, and in children too, restless leg syndrome. And oftentimes we don't think about it, or we wouldn't really report that to our primary care doctor unless we specifically ask. And the ask would be different. If we're talking about adults, you can always say, hey, have you had any challenges or urges to move your legs at nighttime? Like feeling a very uncomfortable sensation that will only go away if you start moving your legs or if you walk around, and the adult person can say yes or no. For a child, it's different, especially depending on the age.
Right. Some just can't calm down no matter what, it seems like.
Yes, so that's what they would say. My legs feel like kicking. I feel the creepy crawlies. I feel like bugs are crawling all over me. And they would ask their parents to please rub their legs at nighttime. And then the parents, as we talk about it, would kind of say, oh, yes, they always need me to rub their legs before bedtime. Or they always report that there's something in the bed. And when I check, there's nothing there. And that's kind of the restless legs would present in a child versus an adult that would clearly say yes or no.
Right.
And there is an association between restless legs and ADHD. So about I would say 13 to 47% of the patients with restless legs do carry a diagnosis of ADHD.
Wow.
Right? Interesting.
That is a high number.
Yes. And for a person, let's say an adult that has been diagnosed with restless legs, they do have a higher tendency to have an offspring with a diagnosis of ADHD.
Mm-hmm.
So it's just that first line relative,
Right.
heritability, excuse my English,
Right.
that we see in these conditions.
Okay.
There's always a first line relative. When
Yeah.
you ask, there's typically somebody else in the family with that type of health condition.
Okay.
And the treatment is easy, to be honest with you. For a pediatric patient, if they don't have obstructive sleep apnea, you can proceed and do iron indices. We believe that restless legs is associated with low iron levels in the brain. Obviously, we're not going to proceed and do a brain biopsy
Right.
in patients, but we do check serum ferritin levels. And based on that, we can say how low your iron storages are and when we need to supplement or not. Usually, for children and adults, once you treat the other health disorder, most commonly sleep apnea,
Right.
those symptoms tend to subside. If they're still present, you proceed with supplementing iron. And if they're still present, then there are other types of treatment modalities.
So it all goes back to, this almost every podcast we do with doctors, it comes down to eating right in a lot of instances too, that just affects so much in your life. If you're having deficiencies of any sort of vitamin or any sort of nutrient, you guys, that's what you see, and that's like, come on, eat a piece of broccoli for God's sake, and let's see if we can fix some of this stuff.
Yes.
So do those that must play? You mentioned circadian rhythms. Can you explain that really quick? I think some people know what it is because we've heard the term quite a bit.
Yes.
And social media will throw it all over the place, but I don't know if anybody really knows what it means.
Yes. So a circadian rhythm is when our bodies respond to different stimuli during the day. Usually the most potent stimuli that we respond to is light. So we interpret the light through our retina, and the retina will stimulate certain areas of our brains, and then that would inhibit the production of melatonin. Therefore, we are in wakefulness, and that will kind of allow certain neurotransmitters to be and to maintain wakefulness.
Mm-hmm.
As that process tends to go down when the lights get a little dimmer or it's just dark outside, your body will respond to that by releasing other hormones or neurotransmitters, in this case, melatonin. So every organ in our body is displaying some sort of circadian rhythmicity. In this case, and for sleep purposes, we are interested in our brain's circadian pattern. There is a little bit of a mismatch in terms of the hours that a regular circadian rhythm has, where in comparison to our own biological clocks, it's just a few minutes. It's like 20 minutes overall, give or take. But there is a little bit of a mismatch, and some people are more sensitive than others, and that's part of the reason in how we can see some circadian sleep disorders. Some of them are most common in the elderly, and some others are more common in children.
Right.
That's why you see teenagers going to bed at 2, 3 a.m., having issues waking up the next day in the morning.
Is that really because of that rhythm?
It's maturing, yes.
Yeah.
So you have two processes when you go to sleep. You have process S, or the adenosine type of process, and I'll explain in a few seconds what
Please.
that means, and then your circadian rhythm. So your process S, or adenosine, is when we, for instance, use ATP. Every cell of our body, that's the fuel that we all use, adenosine triphosphate. And as we use that adenosine triphosphate just to articulate some words, to think, and all these things, we start to accumulate a metabolite that is just called adenosine. We lose the phosphates, the 3 phosphates associated with that. The more buildup of adenosine we have during the day, the more tired or fatigue we'll be. If you add that to the circadian rhythm, you can see those two lines going together. At some point, especially at nighttime, you'll have enough fatigue or accumulation of this tiredness that will promote something we call sleep pressure. We're just very, very tired. You have all of that adenosine build up, and now the lights are out and it's dark outside, so there's nothing else for your brain to do other than to finally get the rest it needs.
Right.
So that's how we normally sleep. If you have any alterations in that type of circadian pattern or in your adenosine buildup, then you'll have more challenges falling asleep. That's why caffeine works, because caffeine inhibits adenosine. So it doesn't allow you to feel sleepy or to get that tired during the day. And that's why we discourage patients to drink any type of caffeinated beverage after 3, 4 p.m.
Okay. Wow. All right. I love it. That was way more than I was ready for, but you explained it so well.
Okay.
That's what made this, that's perfect, because like I said, we talk about and we hear, and here I'll ask you in a minute about things that drive you crazy about sleep myths that I'm sure with social media, specifically things that you see, you're like, oh, come on. And you've mentioned melatonin a couple times. And of course, there are melatonin supplements that people can take. And you always seem to come across those when you're watching TikToks or other social medias about when you should take them, how much you should take, whatever. Never from a doctor, of course. What's your take on that?
Well,
you can be completely honest. That's what's great.
Okay, I'm glad. I'm glad.
Good. Yeah.
So ideally, you shouldn't need anything to help you fall asleep. If you are requiring some form of medication to help you fall asleep or supplement, we need to address the actual root cause of the problem. Is it sleep apnea? Especially in women, sleep apnea usually presents as insomnia type of symptoms. So we have to be very, very mindful of that, especially when we are transitioning into that perimenopausal period where our hormones start to shift.
Yeah.
And with that, even our muscle or our body composition changes. We start to accumulate more fatty tissue, then we're more prone to develop obstructive sleep apnea. It wouldn't necessarily present as loud snoring, nocturnal gasping, pauses in your breathing. It may be more subtle. However, those are the typical symptoms.
Okay.
People tend to have a lot of night awakenings, challenges falling back to sleep, or even then problems initiating sleep. So people recur to melatonin, Benadryl, Tylenol PM, and all these other stuff that are not beneficial.
Right.
Why? Data, which is what most of us use to kind of direct our treatment.
Thank God.
Yes. Doesn't really support the benefits of taking melatonin. Is a supplement, so it's not really FDA regulated. You don't really know what you're taking. I think it was 2 years ago when they did an experiment, and most of them were sugar pills.
Wow. Well, a lot of them come in the gummy form, too.
Yes.
So, yeah.
No melatonin whatsoever. It was just sugar, especially the ones
goodness.
targeted to kind of melatonin for children.
Right.
So what's the benefit in that? You're creating the opposite effect at that point in time. But we don't know. We are consumers. We have no idea. We're believing whatever the label says.
Right.
So if you're thinking about using melatonin, the first advice I would say is to make sure it says USP, verified. It's it's kind of like one of the groups that pharmacological groups that actually make sure that whatever they're saying or stating in their label is correct. So USP verified melatonin, number one. Melatonin has certain indications within the sleep realm, to be honest with you, and we'll talk about that in the future, but RBD is one of the indications.
Okay.
And when you're trying to transition somebody with a circadian sleep disorder to a more stable or a more conventional sleep pattern. Otherwise, there's not a lot of indications in sleep. Why? Because let's say that if you're talking about insomnia, most of the patients, when we look at the research studies, it's just a placebo effect. And if there is any improvement, it's only like by 10 minutes. How is that really significant? And then it has side effects. People may be more prone to experience nightmares, bad dreams, maybe be more restless in their sleep at night. So really you have to consider if the risks outweigh the benefits at that point in time.
Are there any supplements that work? I know magnesium is another one that a lot of people will talk about too, to help them sleep, or even
chamomile tea.
Chamomile. Well, that's another good one. Do any of those? I mean, I know you guys, those aren't, like you said, they're not really FDA approved or regulated or looked at. But is there any you feel that people can start with if it's not super serious for them? If maybe they just have a couple of nights or whatever, are there things like that that you feel work?
Well, It depends because
Sure.
of that placebo effect.
Yep.
Some people may report it does work for me, and that may be true to them. So I'm not against, and I don't usually take my patients off magnesium if they're taking it,
Right.
or chamomile tea if that's part of their routine.
Just
By all
tastes good.
means, yes. From my end, I'm not opposed to it.
Right.
I wouldn't prescribe it
Sure.
because it doesn't. I don't have the data to support that. However, I wouldn't really remove them or advise them against it.
Okay.
We don't have enough data, and if they feel it's helping, by all means.
As long as you don't abuse it, just like anything else,
Correct.
for sure. Are there, let's talk a little bit about, are there things that just drive you crazy when people come in and talk to you and they say, well, I've read this or I've seen this, or why don't you guys do this? Is there anything like that that you're like, well, here's why? I mean, are there myths about sleep that you struggle with?
To be honest, not really.
Oh,
I love
that's
to have
good.
that opportunity to educate the patients.
Yes.
Even if they come in with a long list of complaints, that only tells me that it's really important for them to address their sleep concern. So I think those are very good patients to educate, orient. The only thing that probably gets me a little bit is when you spend an hour counseling the patient, explaining why, and then they may say, nobody told me this.
Oh, sure.
That's the only part
yeah.
where you say, oh, but after you spent all this time, I really tried. You said that you understood everything. I answered all of your questions. Why now, after the visit? Why?
Oh,
2 weeks
boy.
later,
Right.
nobody told me that.
Yes, we did.
Yes.
So, like, if you had to give some advice to adults and parents to improve sleep,
Yes.
what are some, again, stop smoking, don't drink really before you go to bed, no caffeine. Are there other things that people should know that, again, you feel like they didn't listen to you the first time when you told them that they should know?
It depends. I
Yeah?
honestly can complain about my patients.
Right.
They tend to be pretty good. But I would say consistency is important. Having a consistent sleep schedule is fundamental. Making sure that you're only in bed whenever you feel sleepy, ready to either fall asleep or to have intimacy with your partner.
Yeah.
Otherwise, stay out of the bed and go to the living room.
That's a piece of advice that, because a lot of people anymore will take their phones in, lay on their bed, and 2 hours later, like, oh my God, it's time to go to bed, right? So then that, I suppose, could really mess up your sleep schedule, couldn't
Absolutely. It goes back to that conversation because we are responding now to that blue light stimuli.
Right.
And so our brains are like, oh, I guess no time to release melatonin.
Yeah.
Maybe later, not now. So you're really impacting the quality of your sleep when you're having those types of behaviors. Granted that we all do it at some point or another. None of us are perfect. But if you try to adhere to some sleep hygiene
Oh, that's a good term.
measures.
Sleep hygiene.
Yes.
I like that. Yeah.
So making sure, and stimulus control, those techniques that I was just mentioning, they're usually called stimulus control, and that's part of the protocol we use to treat patients with insomnia. As of now, that the most not the most common, but the most effective treatment for insomnia is cognitive behavioral therapy for insomnia, where it's just multiple strategies that can help the patients kind of navigate what are the issues with their sleep, identify the issues, and then kind of retrain their brains to sleep.
Right.
That's what we do. It's sleep training for adults, basically.
Perfect. You mentioned, you off the air, you mentioned that you are originally from the Dominican Republic.
Yes.
Do you notice sleep differences in people from the Dominican Republic and people in the United States? Have you ever thought about that? Have you ever thought that, yeah, we do it right, or they do it right, or are there differences, or are we so connected on the planet at this point that everybody's kind of doing it the same way? Do you notice differences at all?
Well, I would say that we're very connected, so
Yes.
it's hard to say. However, daylight savings is something that is really impacting our sleep here in
Yes.
the United States.
You don't have it in the Dominican
We don't
Republic?
have it. No.
So smart.
And so I would say that's one of the things. We can really see an increase in car accidents during daylight
Right.
savings. It's just not really helpful. And that's something the American Academy of Sleep Medicine has advocated over the years to kind of get rid of daylight savings.
Which way would you like it to be? Like it is in the summer or like it is in the winter? Like
this-
now.
like it is now.
Yeah,
That's how it
to
should
get
be.
rid of the change that happens in the
Yes.
spring.
Correct.
See, you tell people that and they're like, no way, why would we want less light in the summertime? Well, so you can sleep better for starters. maybe. I don't know. Listen to the doctors. For sure. Well, Dr. Catherine Fernandez, thank you for coming in and talking about this.
Thank you.
Kind of giving us an overview. And I know we're going to have you back because there's a specific topic we want to get into, which is called REM behavior disorder. That I know I think you're pretty excited to talk about too. So next time we have you back, let's get into that, okay?
Thank you so much. It's been a pleasure.
Thank you for coming in, Doctor.